Hello, and welcome to today's webinar, Catalyzing Insurance Reform in California. My name is Monica Bryant, and I'm the Chief Operating Officer for Triage Cancer. Before we get into the heart of the topic, I just wanted to go over a little bit of housekeeping. All callers will be muted for the duration of the webinar. If you have any questions or technical problems, please type them in the chat box to the side of your screen. This webinar is being recorded and will be available for viewing on our website at triagecancer.org. And at the end of the webinar, we will be encouraging you to ask some questions of our wonderful speakers today, so please stay with us. A little bit about Triage Cancer for those of you who don't know us. We are a national nonprofit organization that provides education and resources on the entire continuum of cancer survivorship issues to survivors, caregivers, and healthcare professionals. We host a speakers bureau of experts and survivors. One of our speakers today is a member. And we host an educational blog, provide online resources, and participate in seminars, webinars, and conferences all over the country. And we know that there are lots of questions about survivorship issues. And so in addition to our webinars like this one today, we have many more learning opportunities, including our educational blog, quick guides, and charts of state laws that might be of interest to you. And just as a preview, we have a couple of upcoming webinars this spring, including we'll be inviting Alice back in May to talk about creating a family after cancer, some information about dealing with medical bills, and some information on nutrition. And all of that information, including the registration links, can be found at triagecancer.org/webinars. So without further ado, I am delighted to introduce our presenter today, Alice Creasy. Alice wears many hats. She is a young adult breast cancer survivor, mother to 2.5-year-old son who was conceived from her own fertility preservation. She is the founder of Fertile Action, an advocacy organization who co-sponsored 2 fertility preservation bills in California and has established the lowest cost egg freezing network in the state. And finally, she is the Government Affairs and Patient Advocacy Consultant for California Cryobank. She is truly an expert in this area, and I am so excited to be partnering with her and these organizations on bringing you this webinar. So without further ado, I'm going to go ahead and turn it over to Alice, and I am delighted to hear all that she has to offer us today. Alice?
Thank you. Thank you so much, Monica, and welcome everybody. This is only the second time that I've done a webinar on this topic, and it makes me laugh to hear Monica say she's an expert in this area, because I truly never expected to be delivering an insurance reform webinar to anyone in the world, let alone be considered an expert in the space. So it might be a little bit of an overstatement, but I'm grateful anyway. And I love Triage Cancer. I love what Monica has done with the organization, and I'm very grateful for the partnership, as well as for California Cryobank, who for many, many years has been supporting cancer patients and survivors accessing assisted reproduction to help them build their families. Today is a really exciting topic. I do want to give some background information on kind of where fertility preservation has been. I recognize a couple of the names on the attendees list and some of these physicians who I've worked with for years now. And our biggest frustration has been how do we make sure that every single patient can access fertility preservation where cost is not the primary barrier? So in 2008, there were only 2 nonprofits that offered financial aid programs, and that was Fertile Hope back then, that then was acquired by Livestrong, and then my charity, Fertile Action. And we headed into 2011 having this ongoing conversation. How do we make sure that insurance covers this? Well, we worked with ASRM and Shannon Smith Crowley, who's a wonderful friend and advocate, on authoring a fertility preservation bill. It was stalled into a 2-year bill. And in California, when you have a bill that turns into a 2-year bill, 99% of the time it kills the bill. So in 2011, we also had a breast cancer patient whose insurance denial was overturned by the Department of Managed Healthcare. But I didn't know that in 2011. So that takes us to 2013 when we presented the bill again. This time, we sailed through the California State Legislature, got to Governor Brown's desk, and he vetoed the bill. You can imagine how upset I was, along with many, many other advocates. He cited cost as the primary issue. In 2014, a number of us advocates met with the California Department of Insurance, and they recommended a different strategy. They recommended a strategy where we would ask professional societies that insurance carriers look to for input on what they should and should not cover to change their standard of care language within those professional societies. We had never gone after that avenue before, and we really didn't even know how to approach it, but we headed into 2015 thinking and trying to strategize how do we make that happen. Towards the end of 2015, the beginning of 2016, we caught wind of what happened in 2011 with this breast cancer patient's use of this appeal system that is protected by the Affordable Care Act. And Monica and Triage Cancer are experts in the Affordable Care Act, so if you have specific questions related to that, she will answer those. So we met with the Department of Managed Healthcare, a number of us advocates being the royal we, and they advised us about this appeals process being so underutilized and that this could be the avenue for us to once and for all in California secure fertility preservation insurance coverage for everyone. Everyone being for those dealing with a cancer diagnosis. Now, to understand why the denials are happening, you have to understand that there are two buckets that these insurance carriers are using to assess whether or not they should be covering these benefits. So in a sense, they have an easy out because in California, the infertility benefits bucket does not require anyone cover infertility services. I'm sure everyone on this call has read the news that there are tech companies out of Silicon Valley and some big consulting companies and other large companies who are starting to cover fertility preservation for all their employees. That's wonderful news for the people who work for those companies who might be facing a cancer diagnosis. But every other company, it's up to them whether or not they cover infertility or fertility preservation. So what that means is that if very black and white, if you have a plan that does not cover any infertility services or fertility preservation, then these insurance companies can automatically deny you fertility preservation coverage because they're not using a cancer care bucket to evaluate whether or not you should receive that service. Now, we've kind of taken offense to that as advocates. We know it's not personal to them. We know it's just doing business for them. But we came up with over 35 different aspects of cancer care, and there's probably more. 35 is how many we came up with just off the top of our head of areas that they will cover. Wigs are oftentimes included. My big example is, of course, always breast cancer reconstruction is covered. And if you are facing a chemotherapy treatment that has a known side effect of cardiovascular issue, it could hurt your heart, then you actually are required to go see a cardiovascular specialist, a heart doctor, and you have to work with that physician in your follow-up care to make sure that they're doing everything they can to prevent the damage, and then, of course, then to help you deal with the side effects of that chemotherapy. So we've always taken the position of why wouldn't reproductive health be considered in the same vein? And that's what we're really after today in working with the Department of Managed Healthcare. So to understand why the Department of Managed Healthcare, you have to understand how all of California is managed from a regulatory environment. There are only two departments who oversee all the insurance plans in the whole state. There's the Department of Managed Healthcare, and they're responsible for 25 million insureds. The California Department of Insurance is only responsible for 5 million. That's really good news for us because the Department of Managed Healthcare has an amazing group and an amazing woman you'll learn more about today who is very collaborative with causes like this, with advocacy groups, and making sure that Californians are getting the kind of health care services that they need. Now, they regulate 122 plans. So 25 million people, because most of their plans are the type of plans that adolescent and young adult patients have when going through cancer treatment, we will see the majority of these patients being covered if everyone starts utilizing the appeals process, and we end up being able to ask for an all-plan letter. from DMHC to all the insurance carriers. So this is how they're willing to help, and this is how they can help. So far, in their Consumer Help Center, they've helped 1.6 million Californians resolve complaints and issues with their health plans. Now, these services are free. They are confidential. And what's really amazing, 60% of those who request help receive the treatment that they're seeking after going through an independent medical review. If an IMR, that's the acronym for independent medical review, if an IMR is in the enrollee's favor, then that health plan has to abide by the requested service. Why is that so interesting to us is because in 2011, that's what this breast cancer patient did. But what's so sad and shocking is she's the only patient to utilize the system. So even in the last 4-ish years, 4 to 4.5 years, now that we're in 2016, she's the only one to go through that appeals process. Now, there's a couple of reasons why probably other people are not utilizing the appeals process. And one of them is because a lot of the people who are managing billing for these enrollees and for these patients are simply in the habit of not filing a prior authorization request when a plan says it's not covered. So we are going to request that everyone on this call and everyone in California, regardless of whether someone has a covered benefit or not, that lists fertility preservation or infertility services, submits a prior authorization request for their patient. Now, this advice came from Mary Watanabe. I probably missay her name every time I try to say it. She'll forgive me, I hope. She is a Deputy Director of Health Policy and Stakeholder Relations at DMHC. She's fantastic to work with and is also very close to this issue because she will share with everyone that her husband has been dealing with cancer. What she recommended to us is that if we show a trend of complaints and IMRs in the DMHC system, then her organization can send an all-plan letter informing insurers that they need to cover this unilaterally, that they can no longer look at the infertility benefit. They now have to look at that cancer care benefit column, and they just need to start covering it. So there's no reason, because of the statute's kind of limitations of the process, to not go back to the patients that you supported in the last 6 months and recommend to them that they go ahead and ask their insurance company, they submit for reimbursement and ask their insurance company to cover their fertility preservation services. The way that it works is really straightforward. The big step that I'm hearing from fertility clinics that they weren't doing in the past, that hopefully they will now do starting tomorrow, is the reproductive billing manager would submit a prior authorization request regardless of the type of plan, regardless of what the benefits say. It's simply a step in the process that has to happen, even if it seems that it's not a pathway that has made sense in the past. HMOs, PPOs, health savings accounts, all of them. Now we would have the prior authorization request. I have some tips on when you submit those to make sure that it's handled in an urgent fashion. The second step is, let's assume everybody gets the denial, which we're assuming would happen. That's historically what has gone on. Then the patient themselves files an expedited appeal through their plan's grievance appeals process. Now, all plans have an expedited method to do that. Usually the prior authorization request, if you list it as urgent or critical, those are those buzzwords. It's usually responded to in 24 hours. The patient filing their expedited appeal usually is 48 to 72 hours. So you can see we can already get 2 denials within the first 3 or 4 days of accessing this process. Then the third big step in filing the IMR. So at that point, once the patient has received the denial to their one appeal from their plan, the patient would then use the DMHC website, which is a very simple website to use, and they would file a request for an independent medical review. And they will receive a response within 7 days. This prior authorization request is to the patient's insurance company, as most of you know. Write urgent at the top. Include a letter of medical necessity. We do have a sample letter of medical necessity on the OncoFertilityUniversity.org website. And then you would use V codes, which are used for showing that it actually is in the cancer column. So the V codes listed here are V26.42 for an encounter for fertility preservation counseling, and that'll cover the consult. And then the V26.82 is for the procedures prior to cancer therapy. Those are important because those are the V codes that need to be consistent throughout this appeals process. That's an easy step. It's faxed immediately, handled in your billing manager's office. The second step is the step that your patients might need a little hand-holding, and that's what we're here to help with. There are lots of organizations who are supporting this cause right now, and we want to make ourselves as available as possible to everyone. So every health plan does have this expedited grievance complaint or appeals process that's regulated. Now, the plans are required by law to resolve any complaints within 30 days for non-urgent cases. So usually for the urgent cases, we see them being resolved in 48 to 72 hours. Most patients can file a complaint by phone, mail, or even a website. I've seen a lot of the big six insurance carriers on their websites, they have a method for an appeal. So your patient can take the letter of medical necessity that your office wrote and, with your documentation of the patient's diagnosis, and they can submit that along with the request for coverage directly through the website. But once they receive that denial at that stage, then they can turn around and submit for the IMR. Now, at this phase, they may also want to add a certificate of immediate health threat from their oncologist. So the certificate of immediate health threat from the oncologist is slightly different than your letter of medical necessity, but very similar. So the certificate of immediate health threat really establishes the urgent nature of this, which is, if this patient is going into cancer treatment in, say, 2 weeks or in 3 weeks or a month, and their window, or perhaps even the same day, as is the case with a lot of the leukemia and lymphoma patients that we know of who are diagnosed in unit and may only have a chance to collect sperm the same day that they start treatment, or they may have to do an ovarian tissue removal the same day they have to start treatment. So in those cases, it could make sense to also add a certificate of immediate health threat that says, hey, they're starting treatment immediately. And that treatment is going to pose a threat to their reproductive health, which is unrecoverable in certain instances. Now, once the patient requests an IMR, the request for the IMR is from the DMHC's website, and there is an alternate plan in the California Department of Insurance, or a parallel path, I should call it. However, they predominantly are covering Medicare, not Medicaid, so we are going to just focus on DMHC for this year. And if there's, patient by patient or ad hoc that do have plans covered by the Department of Insurance, I'm happy to support them figuring that out, but our collective efforts this year are on DMHC. Now, that IMR is an objective review by doctors outside the health plan. So that's one of the things that is so unique about the IMR is that it is not hired help by the health plan itself. There is a statute of limitations. They must submit the request within 6 months after their health plan sends a written decision about the issue. As I mentioned before, the non-urgent IMRs and typical consumer complaints are decided within 30 days, but those expedited IMR complaints they receive a decision within 7 days. So for my fertility preservation specialists who are on the phone, my IVF doctors who routinely do egg harvesting and egg retrievals, you can imagine this entire process can actually be rectified before someone even has their egg retrieval day. So if they start stim, if they do a rapid stim cycle, and on day one that they see you and your billing manager submits that prior authorization and gets the denial and all the steps are filed, then the entire issue can be resolved before someone heads into egg retrieval day, which is pretty astounding and very different than what we used to do in the past, which is kind of, usher people through just getting the fertility preservation treatment done, offer as low cost, offer all these financial aid programs to them, offer free medications through Faring, through EMD Serono, and then have the patient raise money from family and friends, or have the patient submit for reimbursement on their own. And by that time that all that is done, and patients are in treatment now, they're in cancer treatment, they're under so much more duress, and the last thing that they want to do is deal kind of with more paperwork and more headache, and so it'll fall by the wayside. So we really want to see this happening kind of simultaneous to the one most empowering thing that they're doing for their future when they're diagnosed with cancer, and that is preserving for their future fertility. Now, there is something called a consumer complaint that we do recommend everyone still utilize. Your clinics can utilize this. Your patients can utilize this. So if there is a delay in getting an appointment, in getting a referral, in getting authorization requests, if there are any kind of billing issues at all, so anyone who was denied in the past, they can even just file a complaint that says, hey, my insurance company denied me on the basis of being infertile, but I'm not infertile yet, and I disagree with that. We want that to be marked as a complaint in the system. And then, of course, if there's any major terminations or cancellations of health coverage, of course, we want that to be logged in the system. But also, other complaints about the plan or the way that they go about doing this. Continuity of care can be a big issue in cancer care, and perhaps you're a physician that's in network today, but you're not a physician that's in network in 6 months, and that might be really, or even in 3 years, and that might be upsetting to the patient because they want you to be able to do their frozen embryo transfer when they get to the point of even starting a family. All of these patient concerns and what DMHC considers as complaints will help the overall cause, so that DMHC can see this pattern and see this trend, that this really is a big issue. This is something that is happening on a daily basis, where patients are not either accessing fertility preservation coverage in a timely manner, they're not accessing services in a timely manner, or the worst case scenario is, and we all know these stories, patients are choosing less effective forms of treatment to try to protect their fertility, or they're choosing less effective forms of treatment to try to have a child prematurely because they didn't have not prematurely as in give birth prematurely. I apologize for choosing that language. But if they try to go off of treatment too early to try to have a child because their window is diminishing, and then they have poor health outcomes. Whereas if they had frozen gametes, they could have waited to the appropriate time, been released appropriately after having finished a complete course of the recommended cancer treatment, and have the longest possibility of healthy prognosis that they could. So this slide is what the Department of Managed Healthcare website looks like for an IMR, and you can see I took this graphic right from their webpage on the 60% of enrollees. So this is very, very easy. There's a form in Spanish and there's a form in English, and I would recommend using these links because if you go to the right box over here, the green box, those are repetitive links. So you want to use the ones that I outlined here in red, and it's very, very simple when you click through there. But they don't require a lot of information. Now, for fastest processing, you do want to submit the letter of medical necessity and provide medical records only if the services are out of network. So, for instance, if you are a provider that is not in the Anthem network, then you want to make sure that your patient is armed with their medical records. Otherwise, DMHC has access to their medical records. So because of how the systems are all connected. So it's faster if you're in network, but not by much. It's faster for DMHC, but not by much. Then on the form, you also just, again on the IMR, they want to indicate that it's urgent or an emergency issue so that it does require the expedited review. Otherwise, they could take 30 days. And then that physician certificate of immediate threat to their health is, from the oncologist side, is really helpful. And then there is an option for patients who need help. The patient can sign a data form to include an authorized assistant if assistance is necessary. So again, these are really quick steps. So if the patient is already bogged down with treatment, or they're heading into brain radiation, they're heading into really aggressive chemotherapy, they're going to be in unit and they're not going to have access even to a computer. These are reasons to have an authorized assistant information, and it's just important for you all to know that when the patient is probably asking you questions, that's available to them. Now, there are quite a few resources available to help everyone. The healthconsumer.org website is fantastic because they have local groups. So San Diego has a local group, but there's local groups through healthconsumer.org where folks can actually walk into a local office and receive help. So if you go to healthconsumer.org and you are, let's say you're based in Los Angeles, there are local groups that you can point your patients to that can go into that office and have them help them fill out all the right paperwork. MyPatientRights.org is an amazing website that is a fantastic resource for patients as well, that also walks them through this IMR process. Folks can email us at Fertile Action. The Oncofertility University website was set up as an initiative, a training initiative. So oncologists, nurses, anybody really can take a male course or a female course. But we also have sample letter of medical necessity and certificate of immediate health threat on there, because we just don't believe that everybody has to reinvent the wheel over and over again. We just want to make it as simple as possible. So I'm going to open it up. That actually went a lot faster than I expected, and perhaps that's because I'm doing my East Coast talking fast. But I am going to open it up to some questions, and the first one that I see are patients able to seek prior authorizations for the purpose of seeking reimbursement after the fact? So the answer is no. They don't seek prior authorization for the purpose of seeking reimbursement after the fact. So the way that they would approach that, let's say the patient already paid, then how do they access this system? If the patient already paid, they're going to submit a request for reimbursement to their insurance company. And if they have that reimbursement denied, then they can file an appeal, and then from the appeal, they would go ahead to the IMR process. So the only difference that changes if someone is already paid for services is that your office would skip the prior authorization step, and then instead the patient would do step 1, 2, and 3. What other questions do we have? There have to be more. Okay, so other than doing the prior authorization, what are things that the HCPS can do to help patients through all of this? And what is the HCPS? Monica, can you clarify what the HCPS is for me? Oh, healthcare professionals. Thank you. Thank you. So a couple of things that you could do, the healthcare professionals, in addition to the prior authorization, is anyone that you've helped secure fertility preservation in the last 6 months, any of your patients, is I would send them a note, and I would let them know, that this is a possibility, and that they do have a pathway, and that question on the prior authorizations versus seeking reimbursement is really a great avenue to say, hey, I took a webinar, and the Department of Managed Healthcare themselves are advising that the patients access this system. We know it's the most underutilized system. So I think that advocating to your patients that doors are opening and could have been opened years ago, which are, heartbreaking but exciting by the same token, because I consider all the people that didn't access the system in all these years that it's been available. And so I'd say that we just have to advocate, for them and on behalf of them, and just empower them to ask for what rightfully should be a health service for them, during this time. So I think really it just boils down to that, which is, let your patients know. Let your staff know. A lot of times patients get really close to a nurse in an IVF clinic, and that becomes their confidant. Make sure that the nursing staff knows about this process. this webinar will be available online, and everyone can flip through these slides and hear my presentation again to make sure that they're all following the same amount of information, and then encourage them to file complaints when they are dissatisfied with the outcome. Our hope and our expectation is that through just the appeals process with someone's insurance company itself, that we're not going to see as many IMRs in the system, because insurance carriers are going to start saying, yes, you're right, you deserve that treatment, and that should be looked at in the cancer care bucket. And when it does get to IMR and we do see 12 even overturns of the denials, then at that point we can go back to DMHC and ask for the all plan letter to go out to the insurance companies. But the exciting thing for all of us advocates, this year, is that we have a very clear path, and we have a regulatory body who is wonderful and working directly with us hand in hand to advise us on how to make sure that these patients access the appeals process the correct way. And it may seem just difficult and overwhelming that we need kind of to mobilize everyone in this way, rather than DMHC just saying, okay, well, we'll go ahead and approve this. But they are a regulatory agency that does need to see the trend first. So we really want to mobilize everyone to show that this trend is real. We see more and more patients trying to access fertility preservation, and we see more and more patients who have to forego it because they can't afford it. What other questions are there? In the history of my public speaking career, Monica, I have never, ever come in under the allotted time. I think that this webinar format might be a very good idea.
Yeah, I have to say it's kind of an anomaly, but I think you gave it some amazing information and lots for all of us to think about. So good job in doing it in less time than we thought.
Fantastic. Well, if there aren't any other questions, I do want to say a very special thank you, Monica, to Triage and to you for helping me work through this system and for supporting us and being a partner in making sure that all this information gets to patients, providers, and caregivers. And also just a special thank you to Mary Watanabe, who, is a co-survivor and with the Department of Managed Healthcare and answers all of my questions same day that I have. So if you do have other questions, feel free to email me personally, alice@fertileaction.org, and I'll make sure that we get the answers. And then I also want to thank Shannon Smith-Crowley, who is the ASRM California lobbyist. She's been a tremendous asset, and she's networked through California on behalf of this issue and on behalf of all the patients and all the physicians. And I certainly wouldn't be where I am without her collaboration and her mentorship throughout the years. So I think this is our year, and I am really grateful to all the physicians too who have reduced their fees to make fertility preservation accessible to everyone. And now it's time to rely on the system and let the system do its job, which I think by the end of this year we'll see between 70 and 90% of patients covered by insurance if we do our jobs right.
That sounds like a fantastic plan to me. And just as a final reminder, this webinar will be available online, and we will send out the link to all of you who have joined us today so that you can share it with your colleagues as well. So I think with that, we'll say thank you so much and have a great rest of the day.